Hmm. So hi everyone, hi Rashmi. So we will see questions and let's try to answer. Okay, so shall we start everyone? Yes. So let's quickly start the questions and let's see how many of you can answer the questions. Okay, so all the best. Okay guys, so here is the first question on the screen. Okay, so let me see if you can answer this question first. So this is I'm going to mark it for you so that it becomes easier, right? Okay, so this is a 14-year-old boy. He presents with swelling in the. I'm not going to waste much of your time, guys. I know this is a very crucial time for you to revise and study for your exams. So, yes, we will go very fast because, let it be like a quick revision and quick test and discussion type questions so that I don't waste much of your time. I'll just try to give you as much info as possible, and I'll also tell you to I'll also suggest you the important must read topics which you should go and read before going to the exam. So if you like the today's video, we'll definitely have more test and discussions in the future, right guys? So here is the first question on the screen. So this is a 14-year-old boy and he presents with swelling in the left tibia. The x-ray shows a destructive process with indistinct borders and there is an onion skin pattern of periosteal bone. Histological examination. Now this is very important in pathology, right? It shows you small round dark blue nuclei, and immunohistochemistry for CD99 is positive, LCA is negative. Which tumor is most likely? Very good, Abhilash and Suman, you are first to answer. Perfect guys. So this tumor has some clues which you should catch from this question. So onion skinning, okay, and a young boy, a round cell, small round cell tumor, and a CD99 positivity. Now, if you look at the histopathology, yes, definitely you see that there are blue cells, blue nuclei everywhere. And but what catches your eye here is, look at very carefully whenever they give you this. This is one of the favorite questions of the examiner. Small round cell tumors. Look at the cytoplasm, guys. Look at the cytoplasm. It's very clear here. Whenever you see very blue color nuclear cells with the clear cytoplasm, the first possibility that should come into your mind is Ewing sarcoma. You know why? Because Ewing sarcoma cytoplasm contain lots of glycogen. So if you have to, they can ask you this question also. So if you have to put a stain for the cytoplasm, which stain will you put? So the stain that we use here is PAS stain. So if you put PAS stain, it will be very beautifully PAS positive. Yes, very good, Abhilash and Daffy. Perfect. It's Ewing sarcoma. Now, so last test and discussion when we did, I focused more on the bone tumors. Today's test and discussion, we are going to focus more on small round cell tumors because this is one of the very important questions, guys. So just quickly, let's look at this. When first I'll just take you to the small round cell tumor and then we'll come back, okay, so to the important updates and points which we should know. See, whenever we have small round cell tumor for an undergraduate purpose, for your purpose, apart from Ewing sarcoma, 4 other lesions should immediately come into your mind. First is, look at this image. What do you see here? Can everybody see? These are very dark blue color nuclei, and if you look at, this is the blood vessel, and can you see this blood vessel is also lined by blue lining, okay, blue colored cell. So what is this effect called? So when a blood vessel is lined by blue lining, okay, blue colored lining, what is this effect called? Very good, guys. This is called Azopardi effect. So whenever you see azopardy effect, who's going to tell me which tumor are we talking about? So azopardy effect typically is seen in, very good, small cell carcinoma of lung. Okay, so small cell carcinoma of lung is azopardy effect. So this has to be very clear to everybody. Okay, right. Now, yes, okay, Bilash, definitely. Then second one, if you look at this, okay, so second small round cell tumor which should catch your eye here is, can you see this pink color material inside that blue cells? There is a pink color material inside that blue cells. So who's going to tell me what is this? These are typical your Homer right rosettes. Homer right rosettes. And whenever you see these Homer right rosettes, no guys, it can be a lot of tumors. It can be neuroblastoma, medulloblastoma, even sometimes even in Ewing's, when it is going towards neuroectodermal differentiation, it can also show you these Homer right rosettes. So these Homer right rosettes will always be given with some marker. Okay, so if they have given you like an adrenal mass with Homer right rosette and it is positive for synaptophysin, then immediately your answer should go towards neuroblastomas. Okay, so remember this, these are Homer right rosettes and they can be present in any small any means out of 3 medulloblastomas or neuroblastomas, or whenever we have PNET, okay, Ewing's going towards neuroectodermal differentiation, it can show you these Homer right rosettes. Now, coming to the third image here, which can be given to you as a small round cell tumor, who will tell me this? So let me give you an history. 1-year-old female is having a grape-like mass hanging from the vagina, and when you do histopathology, you see this. Who's going to tell me the answer? Quick. Quick. Let me see how many of you answer this question. Anybody who can answer this question, I'm waiting. Quick. Which tumor is this? Guess, guys, guess what tumor can this be? So this tumor, let me give you a hint, it has an hyper and hypocellular area, especially below the nuclei, especially below the epithelium, there is condensation of the nucleus. So there is a layer where there is all these nuclei are condensed just below the epithelium. And this layer is called as cambium layer. So which tumor I'm talking about which has a cambium layer? Anybody? Let me see who can answer. Hi Arvind. Tell me, quick, who will answer this question? I'm waiting. Okay, so very good. This is embryonal rhabdomyosarcoma. So what is this? This is embryonal rhabdomyosarcoma, guys. And who will tell me? Very good, Vicky. You are first to answer. Good. So chocolate from my side. So when we talk about embryonal rhabdomyosarcoma, remember this is one of the tumor which typically has, you know, the nucleus are tennis racket shaped nucleus. So the nucleus are usually tennis racket shaped nucleus. Okay, shaped nucleus. So that's a very characteristic finding that you should remember. Let's look at this tumor. This is little tricky question and it's an INI-CET level question. So let me see how many of you can answer this. So let's say 70-year-old male presents with the mass in the head and neck area and there's a nodule. And when we saw this nodule basically had small round blue cells, and on microscopy again they had small round blue cells, and then you put IHC, and on IHC CK20 was put, which showed a typical dot-like positivity in the paranuclear area. So paranuclear dot-like positivity is seen in this tumor. Which tumor am I talking about? So IHC showing you paranuclear dot-like positivity. Anybody who can answer this question? Anybody? So this tumor is Merkel cell carcinoma. Please don't forget this. This is Merkel cell carcinoma. Always remember this, okay? Very, very important question. Merkel cell carcinoma is a neuroendocrine tumor of the skin. It has a very poor prognosis, and if you put IHC, it has CK20 dot-like positivity in the paranuclear region. That's characteristic of this tumor. So 4 small round cell tumors, which you should be very clear here, are small cell carcinoma of lung showing you as a azopardy effect, tumor-right rosettes showing you seen in neuroblastoma or medulloblastomas, okay, or embryonal rhabdomyosarcoma, especially in presenting in hollow cavities, okay, showing you tennis racket shaped nucleus and cambium layer, Merkel cell carcinoma, a neuroendocrine tumor of the skin presenting with dot-like positivity of CK20. So that should be very, very clear to everybody. So let's look at one question. So let me see how many of you can answer this question now. So this is just an extension of this, okay. Yes, who's going to tell me this? So question here is, which fish testing may assist in making a distinction between embryonal rhabdomyosarcoma and alveolar type of rhabdomyosarcoma? So which mutation you're going to test which can differentiate between embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma? So guys, this is mutations of the soft tissue tumors is one of the question which was asked in your INI-CET exam and a very tentative question. So you must be knowing this, okay. So remember this mutation FAX3 FOXO, okay. So everybody should remember this. FAX3 FOXO is a very typical mutation which is present in alveolar rhabdomyosarcoma. So this is very, very characteristic mutation of alveolar rhabdomyosarcoma. Now this mutation EWS-FLI1, okay, so EWS is Ewing sarcoma, FLI1 is Friend's leukemia virus integration gene, and this is very typical mutation for Ewing sarcoma. So the case with which we started, this is a mutation of Ewing sarcoma. Now SS18 and SSX1 is your synovial sarcoma. Name itself says SS, that is synovial sarcoma 18. Okay, so this is synovial sarcoma. Okay, so these mutations which I am telling you for are very, very important mutations. And ETV6 NTRK3 was your INI-CET question which came. This is a very typical mutation of infantile fibrosarcoma and it came in the exam as translocation 1215 is a very characteristic translocation of which tumor? It is infantile fibrosarcoma. Okay, so that's infantile fibrosarcoma which all of you should remember, and these are the mutations which you should remember. And here is the chart from Robbins which I'm quoting, which all of you should remember. Okay, and I've already in the last test and discussion I've already told you a lot of clues of how to remember it, So if you can go to last test and discussion and see, you'll find a lot of clues to remember these mutations. So this is the chart from the Robbins which I am strongly suggesting must be remembered. So Ewing sarcoma which we discussed has 1122 translocation. Okay, remember that synovial sarcoma, just now I told you SS18 SSX1 is actually X18. It is also called as X18 translocation. Alveolar rhabdomyosarcoma which I just now told you FAX3 FOXO1 is actually 213. And apart from that you have to remember infantile fibrosarcoma which I told you 1215 was your ETV6 or NTRK3. Yes, so this is a very, very important chart which you need to remember in Robbins. So just quoting it and leaving it up to you to just revise it whenever you have free time. Keep revising this chart. And now here is a quiz question, okay, spot question. So again, this is a small round cell tumor. Look at the cytoplasm. It is clear. Which special stain have I put here which is giving a beautiful cytoplasmic magenta pink positivity? So which special stain it is? This is PAS positive. So this special stain here is PAS positive. So this is a PAS positive special stain which you have to remember in Ewing sarcoma. So is everybody clear with this? Yes, so that's very, very characteristic of Ewing sarcoma. Right guys, so that was your question which you should know in this, okay. Now let's come to the question number 2. So whenever I'm talking about question number 2, this is easy question. I am sure all of you will be answering. Everybody can answer this. So this question is which can be asked to anybody, FMG, NEET, PG. This is a very simple question and all of you should be able to answer this question. So let's look at this question, guys. Okay. So here is the question. So this is a 40-year-old female, and she presents with fever and epigastric pain for 4 days, and she presents to the emergency. Her hematocrit is 24, her platelet count is 15,000, her LDH is elevated, peripheral smear shows schistocyte. What is the cause of this disorder? Okay, so if you have ever doubt in hematocrit is what, divide the hematocrit by 3, that's your hemoglobin. Okay, so 24 by 3, that is the patient has the hemoglobin of only 8 gram per deciliter. So patient is having anemia, patient is having thrombocytopenia, she has fever and some epigastric pain, plus there is elevated LDH. Okay, so a patient is having with this fever, anemia, thrombocytopenia and her elevated LDH is seen. So what are we seeing at? So very good, Abhilash, the answer is correct, that is TTP. So this patient, you know, always remember in your mind, whenever they are giving you schistocytes are seen, whenever they give you a very important feature, schistocytes are seen. So remember here the basic clues. Okay, so just I'm writing here. So if ever you are given in exam schistocytes are seen, there are two things you should remember in your mind. Okay, so either it can be thrombotic microangiopathy or it can be DIC. So how do we differentiate these two first? First rule is look at the PT and APTT values. If PT APTT values are increased, then it is DIC. If PT APTT values are normal, then you will start thinking of thrombotic microangiopathies. Now coming to microangiopathic hemolytic anemia. So if it is a child, you will think of HUS. Usually the patient will have a triad of RAT, that is there will be renal function defect, there will be anemia and there will be thrombocytopenia. Schistocytes are definitely seen. Okay, so apart from that, you should also remember atypical HUS which occurs due to complement defect. You should also think about that. Okay, so if infections are not there, atypical HUS usually has complement defects. Okay, or you should also have TTP in your mind, which can be child or it can be adult. Okay, and in this it is usually a pentad. Apart from this, fever and neurological involvements are also present. Okay, so TTP. So how do you differentiate us? You have to go and check for the levels. So for every patients, so if you are suspecting TTP, you will get tested for ADAM-TS. Okay, complement levels if you're thinking of atypical HUS, and usually typical HUS has Shiga toxin or E. coli infections, so you work up for the infective profile. Okay, so now this is how we proceed with this is the approach to a case of schistocytes. Okay, so that is what you should remember. So here a typical feature is given, patient is having anemia and thrombocytopenia with fever, and also there are schistocytes in the blood. Okay, so this is a thrombotic microangiopathic hemolytic anemia could be a possibility, and definitely you will go and test for ADAM-TS. That was the question and that is the answer. So this is deficiency of ADAM-TS. So remember why this is not sepsis. Okay, so if you look at sepsis will not usually have increased LDH, it usually will not have hemolysis. Why this is not von Willebrand deficiency? Obviously if it is worse, von Willebrand deficiency will present with bleeding. Okay, and the APTT will always be given, APTT and BT. Whenever the bleeding time and APTT both are prolonged, think of von Willebrand deficiency. Obviously hypertensive crisis is just a googly option. So look at the schistocytes, guys. You should be able to identify these. These schistocytes are called as helmet cell. Okay, these are called as helmet cells. This is an image from the ASH image bank. So this is a helmet cell which you can see, and helmet cells are very characteristically also called as schistocytes. Okay, and you should be knowing the cutoff. The cutoff is 1% in a tip. Whenever, even if it is more than 1% schistocyte with reticulocytosis, it is very suggestive of thrombotic microangiopathic anemias. Okay, now let's come to the question number 3. So let's see, this is blood banking question. How many of you can answer this question? So this question is a pretty simple question and was also a repeat question from your INI-CET. I think NEET PG also it came. A very simple question but a very prudent and very important question. So this is a 24-year-old boy, and he saw that while he was giving blood for the transfusion, first few ml of blood was going into this bag. What is the utility of this bag? Anybody who can answer this question? So what is the utility of this bag, guys? This is nothing but, yes guys, so very good. So this bag is a very important bag in which the first blood usually goes. Okay, this is called as pre-donation bag, guys. Why do the first 10 to 30 ml of blood will go always into this bag? Because whenever we prick the skin, the first thing that comes is the bacteria which is present in the skin, so it can cause sepsis. So that is why you don't want that to happen. So you send the first 10 to 30 ml of blood into this pre-donation bag, and this is to prevent sepsis. Okay, that's a very easy and a googly question again, which everybody should know. Very good, Sudhakar, you are perfectly clear, correct. Now next question is, which factor has the longest half-life? So out of these, which factor has the longest half-life? Yes, so all of you knows this is some of the question which is very important. So here I gave this question because I wanted you to analyze that there is a factor which is very important. This factor 13 is called as Lacky-Laurent factor, and it is a very important factor because it has a very long half life, approximately from 8 days to 2 weeks, and this factor comes after the clot is formed. So it helps in stabilization of the fibrin, it helps in cross linking of the fibrin, and definitely factor 13 deficiency causes bleeding, especially the umbilical cord stump bleedings occur in these group of patients, and these factor 13 deficiency cannot be picked up by routine coagulation testing, PT or EPTT. So you have to do a special test for this. What is the special test we do for this? Yes, very good everybody. This is called as urea clot solubility test. That's the test which you do for factor 13 deficiency, which everybody should be remembering. Apart from that, all of you should remember that so apart from that, the shortest half-life is of factor 7. Shortest half-life is factor 7 of 6 hours. The longest half-life is factor 13, which varies from 8 hours to approximately 2 weeks, right? So that's the factor with the longest half-life. Very good. Okay, very good, Kadambadi. Your answer is perfectly correct. Okay. Now let's come to the next question. So this question is, antler horn-like pattern is seen on the FNAC of the breast, and what is this suggestive of? So this is an antler horn-like pattern which is seen on breast FNAC. What is the diagnosis of this entity? Anybody who can answer this question quickly? I'm sure all of you will know this. A very important question for your NEET PG especially. Okay, so this is your antler horn-like pattern. So whenever you see these antler horn-like patterns on the FNAC, these are very suggestive of fibroadenoma of breast, which is the most common benign tumor of the breast. Okay, so if you look at this FNAC of the breast, what do you see here is, you see this antler horn, and you look at this stroma. Okay, so whenever you have FNAC of the breast, so first thing you should come to your mind, what is the cell of region of fibroadenoma? So everybody should remember this diagram, and you should remember that fibroadenoma actually arises from the lobular stroma. Okay, so it arises from the lobular stroma. So because it starts proliferating here, so what happens is, so this stroma starts proliferating along with the epithelial cells also. That is why fibroadenoma of the breast is also called as fibroepithelial tumor or a biphasic tumor. So here you will see proliferation of both epithelial cells and the stroma cells. So on FNAC also you will see the same thing. This is the stroma which will come out in the FNAC. Along with that, you will pull the duct also. So usually because of proliferation of stroma, the ducts are compressed. So when you pull out this duct, it comes like a stag horn. So you see lot of stag horn like pattern like this, which is very characteristic of fibroadenoma of breast. Okay, so perfect everybody. So this answer has been answered correctly by Sudhakar, who, I don't know who is evil with the horns, the stag horns, and Kadambadi, Priyanka, very good. All of you have answered this question perfectly. Okay, so yes, you see a lot of stag horns and stroma. Along with that, very important point about fibroadenoma, guys, there is lot of bipolar nuclei in the background. Okay, so these are benign bipolar nuclei. Okay, these are nothing but they are myoepithelial cells. Okay, so fibroadenoma is a benign lesion. So the characteristic feature of a benign lesion of breast is they have myoepithelial cells. So you see a lot of benign bipolar nuclei in the background suggestive of myoepithelial cells, suggesting that this is a benign tumor. Okay, so everybody should be clear with this. So this staghorn is nothing but an epithelial cells, which you should be remembering. Now let's see how many of you can answer this question. Let's try this question and let me see how many of you can answer this question. So if you have understood it, you will be able to answer. So this is a 20-year-old female who presents with 1 centimeter breast lump. The biopsy shows a fibroepithelial lesion. Which histological feature is consistent with the diagnosis of fibroadenoma breast? Let me see how many of you can answer this. And hey, by the way, at the outset, you should be able to identify the histopathology of fibroadenoma of breast. So there is a lot of stromal proliferation, and this proliferating stroma is compressing the epithelial cells, which I told you. And this compressed epithelial cells, when you take it out, it will come as staghorns. Okay. So what do you think is consistent? Which of these findings is consistent with fibroadenoma? Okay, let's see if anybody of you can answer this question and tell me. Okay, so Kadambari says C. See, C is not the answer. Why? You know, stromal condensation. Stromal condensation means it's like stroma which is excessively proliferating just around the glandular structures. This is very characteristic of Phyllodes tumor. Okay, so that's this feature. If you see ever know, then you have to make a diagnosis of Phyllodes. So Phyllodes tumor is different from fibroadenoma because it shows you lot of stromal growth, and this stroma usually condenses around the glandular structures, and sometimes you can even have stromal atypia. So because Phyllodes is one tumor which can be benign, borderline or malignant, so it can show you stromal atypia. So the finding which is consistent with fibroadenoma here is just circumscribed borders. So it has circumscribed borders because it's limited. It is not involving or protruding into the or entering into the interlobular stroma. So it has a very well defined circumscribed lesion, and that is why it is also called as breast mouse, because it has very well defined borders, and you can actually see that on radiology also, right? So perfect. So just remember, Kadambari, it is always good to answer wrong. You know, whenever you answer wrong, you will always remember it. So you should answer wrong so that you never do mistake in your exam. So always you should answer wrong. So I am in a favor of everybody answering wrong. Okay, not correct. Rest, everybody, yes. So that's the answers which everybody has to remember. Remember, the other three are the findings of fibroadenoma. Other three findings are of Phyllodes tumor. The first one is definitely fibroadenoma. Everybody clear with this? Yes. Now let's go to the next question, guys. So this is a googly question. Okay, so very easy googly question. I am sure all of you will be able to answer this. Okay, it's a googly question, so everybody can answer this question. So for which procedure is this instrument used? A googly question. What is this needle? Okay, what is this needle? Everybody knows this, isn't it? I don't even need to tell you. This is a bone marrow aspiration needle. A googly question should also be known to everybody. Okay, so there are two types of needles which are very commonly reusable needles. Nowadays we don't use them, but still you should know. These are Sala and Klima. So whenever there is a screw here, it's Sala. When there's a no screw, it's a Klima needle. And these are bone marrow aspirate needles. So coming to the bone marrow aspirate, so it was a googly question. Let's come to a little tough question. Let me see how many of you can answer this question. And this is a little tough question. So in which of the following condition you mandatorily need a bone marrow biopsy? So bone marrow biopsy is needed over bone marrow aspirate in which of the following lesions? Facile. Googly question means googly balls. You know what are googly balls? Whenever the kid is playing, you will just throw the ball. No, okay, like you play. That's called googly questions. So very easy questions, super easy questions. They're called googly questions. Okay. So which of the so in which of the following bone marrow biopsy is needed more over bone marrow aspirate? Let me see how many of you can answer this question. Quick. Come on, guys. So is it TB? Is it megaloblastic? Is it leukemia? Is it Kala ulcer? Okay, good, Priyanka. You answered this question correctly. So TB. So why do you need bone marrow biopsy? You need bone marrow biopsy over bone marrow aspirate whenever either you have a dry tap. Okay, so there is a fibrosis in the bone marrow like myelofibrosis or hairy cell leukemia, in which you think that bone marrow aspirate will be a dry tap, or whenever there is something in the bone marrow biopsy which will not come in the aspirate, like granulomas. So granulomas usually do not come in the aspirate, so you have to do biopsy in this. Okay, so that is the point that you have to remember. Okay, so in cases of TB, whenever you're suspecting tuberculosis in a person, and you have to do bone marrow biopsy always, because granulomas will not come on bone marrow aspirate. So megaloblastic anemia is very easily diagnosed on aspirate, because you can see megaloblast on bone marrow aspirate. Leukemia blast can be very nicely seen on bone marrow aspirate, so it is very easy to diagnose. Kala azar, you will see Leishmania donovani bodies, which are also very easily seen on bone marrow aspirate, so you do not need to, so even you can diagnose on the aspirate. So ideally it is good to do bone marrow biopsy and aspirate both together, but TB biopsy is mandatory, otherwise you will miss it. Okay. So let's know the lesions which are important, and I gave you in the question here. So everybody, can you look at these? So can you see these lesions here, here, here? So these are basically what? They are Leishmania donovani bodies. Okay, Leishmania donovani bodies. You have to remember, Leishmania donovani bodies typically have a kinetoplast like this. Okay, so you have to identify them. So these are LD bodies which can be well identified on bone marrow aspirate itself. But look at this lesion. Okay, so there is a necrosis. There are Langerhans cells. There are few epithelioid cells here and there. This is a granuloma. It might not come in aspirate and you might miss it. Therefore, in cases of TB, you should always have a bone marrow biopsy. Right, guys? Let's go to the next question. So the next question is, which of the following is not a malignant salivary gland tumor? Okay, salivary gland is a very important lesion for your exam point of view. So you can also see my video on malignant on salivary gland tumors, which I posted on the YouTube if you wish to see. Okay, so which is not a malignant salivary gland tumor is a question which has been asked. So you should be knowing it. What is the answer? Which is not malignant? That means which is benign. Who will answer this question quickly? Come on, come on, come on. Come on, come on, come on, come on, guys. What is it? Which is not a malignant? Which is benign? Okay, pleomorphic adenoma, perfect, Fazil, but that's not in the option. Out of these options, which is benign? Okay, Jason, remember mucoepidermoid is most malignant tumor of the salivary gland. Okay, so most common malignant tumor of the salivary gland is mucoepidermoid. Okay, remember that point always. Right. Okay, so Mastur, adenoid cystic is also a malignant tumor, and K. Nick is saying Warthin's, and that's the correct answer. So remember in this point always. So here is the table which I want you all to remember. So this is the histological classification of the salivary gland, a very simple for the undergraduate point of view, guys. So benign one's pleomorphic adenoma, which Faisal said, perfect. Okay, Warthin is also a benign tumor, which you will remember. Warthin is very good, Jay Shankar. So Warthin is a benign tumor. Apart from that, oncocytoma is the benign tumors, which you should remember. Now mucoepidermoid, adenocarcinoma, actinic cell, adenoid cystic, all are malignant tumors, you have to remember. And most common malignant tumor is always mucoepidermoid. Okay, so most common malignant is mucoepidermoid. Most common benign is pleomorphic adenoma. Right, very good, guys, perfect. Okay, so very good, Arvind, Faisal, Jayashankar, Priyanka, Chris, Nagesh, full points. Okay, now once you're clear with this, now let's see more. Now let's come to a tricky question. Which of the following is most common malignant minor salivary gland tumor of the larynx? So when I'm asking specifically for the larynx, which is the most common malignant minor salivary gland tumor of the larynx? So remember this, in the larynx, usually adenoid cystic carcinoma is the most common. Okay, so most common minor salivary gland tumor is usually adenoid cystic, especially in the larynx. So here is a gist chart which I've made for you guys, and these are I'm actually very fond of making these gist charts which are very important. So this is in gist of salivary gland tumor. Take a snapshot of it and keep it forever. Very important. Okay, so remember, most common benign tumor of the salivary gland is pleomorphic adenoma. Most common malignant, you know, is mucoepidermoid. Okay, so whenever you see a lot of this chondromyxoid pink color material here, think of pleomorphic adenoma. Whereas whenever you see the glands along with some squamous cells, and they've given that, okay, these glandular cells contain mucicarmin positive secretions, then this is usually mucoepidermoid carcinoma. And they ask you the mutations. Remember, the mutations is PLAG1 in case of pleomorphic adenoma, whereas it is MECT, MAML2, okay, in mucoepidermoid carcinoma. Right. Apart from that, you have to remember Warthin tumor is also called as papillary cystadenoma lymphadomatosum because it contains lymphoid follicles, and it is only present in the parotid usually. Warthin is a tumor which is only usually present in the parotid, and it contains lot of lymphoid follicle, and this tumor is usually more commonly present in the smokers. Okay, so usually in the males and smokers, Warthin tumor is more common. Adenoid cystic has a very typical appearance called as cribriform appearance. So you will see lot of cookie cutter holes. Okay, so there will be small holes like this around which tumor cells will be arranged. This is called as cookie cutter appearance, and usually there will be nerves will be involved. So perineural involvement will be a very characteristic feature of adenoid cystic carcinomas. Okay, so these are the tumors which all of you should remember, must remember in salivary gland tumor. Okay, right. So it is MECT. Okay, Aruneshwar, right. Perfect. Now, here is the catch point and a very important question. So this question is for INI-CET levels. Okay, so they can ask you match the classification with the tumor. So everybody should be remembering Bethesda is a classification used in thyroid and cervical cancers. March classification is a classification for celiac disease. Paris classification is a classification used for bladder cancer. Robinson classification is a cytological classification of breast cancers. Okay, Fish classification is for glomus tumor, and Milan classification is for salivary gland. Okay. Okay. Yes, Kadambini, I'll give you that. Okay, so let's quickly know this. This is a very important classification that you should remember. Okay, I'll try to post the PDF just below this session so that anybody of you can, you know, take it. Right. Okay. Now here is the question. Okay, so again, trisodium citrate, that is 3.2 gram per deciliter, whenever you use in the concentration of 1:9 is used for. A very important question again which is asked in your exam. Where do you use this anticoagulant? Where do you use this anticoagulant? Very important question and a googly question also. I am sure all of you remember this is basically used for coagulation test. Remember, the concentration is very important. It is 9 volumes of blood and 1 volume of anticoagulant. This is trisodium citrate, always used in the concentration here is 3.2. Okay, 3.2 gram per deciliter. Yes, and this is citrate. Remember everybody, if you use this in the concentration of 1:4, okay, so this is 1:9. So for your coagulation testing, you use in the ratio of 1:9. But if you use it in the ratio of 1:4, then the vacutainer here is usually black vacutainer, and it is used for ESR by Westergrens. So that is for ESR by Westergrens method. Okay, that's a very important. Very good, Aruneshwar, you get full points for this. Good. Now, at this point itself, you should know order of draw of blood, which I had posted on my Instagram just few days back. Very important on my Instagram and on my Facebook both. Very important. Draw of blood is one thing which all of you should remember. It's very easy to remember. First bottle should always be culture. Culture, coagulation and serum. Okay, always remember like that. Why do you use this? Because for the taking blood in the vacutaneous, you use a needle which is double bored needle. So if you are not careful, what will happen is these anticoagulants can contaminate each other. That is why you don't want any contamination in the coagulation vial. So that's the first vial you will take after your culture bottles. Okay, so that is why remember always culture, citrate and serum, and after that you remember simply HEN, hen. Okay, so then you take heparin, EDTA and sodium fluoride. This is sodium fluoride. So sodium fluoride is for sugar, I hope you remember what is the anticoagulant which is present in sodium fluoride. It was earlier double oxalate, but now it has been made to EDTA only. So because last two are EDTA, so it doesn't matter. Okay, so it should go in this ratio always. So first you take culture, then you take coagulation, then you take serum, then you take heparin, then you take EDTA, and then you take sodium fluoride and EDTA. That's the correct order of draw which all of you should be remembering. Once you're very clear with this, let's go to the next question. Perfect, guys. So again, a very important topic which comes in your exam and you don't read it much, pancreas. Okay, very, very important, guys. So this is a very elderly female, 70-year-old female, okay, senile female, okay, presenting with mass in the pancreas, in the tail of the pancreas. So this senile female has VHL mutation. So S and V come together. Okay, so they are very close together. So S and V, so they have VHL mutation. This is very characteristic of one tumor. Remember, senile tumor in pancreas with VHL mutation. Even if they don't give you gross, you should be very clear that this has to be serocystic neoplasm. Very good, Arvind and Satish, you get a chocolate. Good. So it has to be serocystic neoplasm, which you should remember. And if you remember serocystic neoplasm, there is a very characteristic picture of it. Okay, so this tumor has a central scar. Okay, so if you see, there is a scar in the center, and around that there's small these honeycomb structures. Okay, so all these are honeycomb structures around it. Okay, so it's like a honeycomb structure with a central scar. Always remember, this is serous cystic neoplasm. So serous starts with word S. It starts with word S. So it is always in senile patients. Okay, so serous is always in senile, old age females usually, and they have VHL mutation. Okay, remember, mucinous neoplasms are also very common in the pancreas, and they usually have KRAS mutations. Okay, SPEN is always present in young. Okay, so SPEN is a very trendy name, no? So it occurs usually in a young female, young patients, and usually when the typical mutation that is present here is beta catenin. So beta catenin mutation is very characteristic of SPEN. So remember that point always. It's a very, very important point that you have to remember. And pseudocyst is just by trauma or something, and no mutation is associated with it. Okay, so these are pancreatic neoplasms in a gist, which you should remember here at this point. Also at this outset, you should remember a very important question. They ask you this: which are the lesions with central scars? Apart from serous cystic tumors, you should remember two more lesions which have a central scar. Okay, so there can be more, but these two are must to remember. Okay, so first is focal nodular hyperplasia, which usually has a central scar, and the second one is called as oncocytoma, especially of kidney. Look at the color. This color is very typical. This is called mahogany brown color with a central scar. This is oncocytoma. Focal nodular hyperplasia has a central scar again, and from this the radiating septas are seen. So these are other two lesions with this central scars. Okay. Okay, so Wanderlust is asking what is SPEN. SPEN is a tumor of the pancreas. It is basically it is a solid papillary tumor. Okay, so it's pseudocystic also. There's cysts in that. This has a very characteristic tumor. It has a solid area and it has a cystic area, and in that cystic area papillas are growing. Okay, so that is why it is a solid and papillary tumor together. So that tumor is called SPEN. Okay, so it's solid pseudopapillary tumor of the pancreas. It's called SPEN, and this tumor has a very characteristic mutation, that is beta catenin mutation, and it typically occurs in usually young patients, right? Okay, so now these are the tumors with central scar, which I've told you: focal nodular hyperplasia, oncocytomas, and serocystic tumors of pancreas. Always remember that in your brain and never ever forget it. Okay, very, very important. So oncocytoma has a mahogany brown color, giardia, it's present in the kidney, and focal nodular hyperplasia is a tumor of liver, right? It's a condition of liver, not a tumor. It's just focal nodular hyperplasia. So it's a condition which presents like a nodule in the liver, right, guys? Okay, now coming to the next question, number 10 here. Okay, right. So guys, I hope I'm not boring you and I'm not taking much of the time. So let's quickly see. It's 7:44 by the watch. We'll quickly finish it, definitely, because I don't want to waste much of your time. Let's quickly see this. So this is a 34-year-old male presents with malabsorption. On biopsy from the intestine, an ulcer was found. And what is this ulcer showing? So guys, if you look at this here, can you see this? There are these small structures which are there, and it has some blood also in it. Okay, so it has some vacuoles in it, it has some blood in it. Okay, so these are nothing but entamoeba. Okay, so these are entamoeba, and this condition is amoebiasis. Okay, so what is this condition? Amoebiasis. So this condition is amoebiasis, which you should remember, and they characteristically have flask shaped ulcers. Okay, so they characteristically have flask shaped ulcers. So why do they have flask shaped ulcers? Because these ulcers cannot go beyond muscularis, so they can't cross the muscle. Okay, so they have no option but to spread horizontally. So they come in and they start spreading horizontally, so they become flask shaped. And if you're lucky enough, if you look at the microscopy, you will be seeing these entamoeba, and these black colored things which you're seeing is actually blood. Okay, so they show you erythrophagocytosis. Very good, Sanathan Basu, perfectly answered. Good. Okay, so that's typical amoeba ulcer. At the outset, you should also remember they give you one of the very important organism which causes malabsorption in the GIT, usually in the duodenum. So amoebas are usually present in the colon, but this organism can be present in the duodenum, and he's a tricky one to know. Remember, who is this? This is a smiling boy, okay, and he's a smiling boy with lot of flagella coming out. So who is this? This is the Giardia, okay. So he's the big old man of the intestine. This is Giardia, and remember, he can call malabsorption, and they can give you this image anywhere in the GIT. So these, whenever the giardiasis is there, usually when they do the biopsies, these giardias will fold upon themselves, and when they will fold upon themselves, no, they will appear like these structures. Okay, only thing you will be able to see their half smiles, and this basically appears like sickle cells. Okay, so on the epithelium of the small intestine, if you see these sickle shaped cells, always remember it can be Giardia. Always remember it can be Giardia. Very good, Shanti Swaroop. You get full points, and apart from Sanyatan, very nice. Okay guys, so remember, now whenever we are talking about flask shaped ulcers, this is another lesion in the skin which is also flask shaped. So let me see how many of you can identify this. A very important spotter asked you in exam. Another flask shaped ulcer with lot of pink color structures, rounded pink color structures coming in. What is this? What is this? Another flask shaped ulcer, but this time in the skin. Flask shaped lesion in the skin. So let me see anybody who can answer this. Quick. I'm waiting, and I'm seeing if anybody can answer. Quick, quick, quick. Your timer starts now. 1, 2, 3. Come on, guys. Very good, Sanatan. This is molluscum. Good. You get full points. Okay. So this is molluscum contagiosum. Okay, so very good. Okay, very good, Shanti Swaroop also. Very, very good. Okay, so these are your molluscum contagiosum. Remember this, guys. Again, a very important spotter that comes to you in exam. Okay, so eruption of these pink color bodies which is coming out. Molluscum, right, guys? So that's about flasks we have talked. Flask shaped ulcers in the intestine, flask shaped lesion in the skin. You should be clear with all the flasks, isn't it? So now let's come to some mutation question. Okay. Okay, very good, Sanjana. Perfect. Full points, right? So identify the correct sequence of the adenoma carcinoma sequence here. Can you answer this? So what's the correct sequence? That's a very important question that occurs here. So remember, first thing which will occur in the colon cancer to form adenoma is loss of tumor suppressor gene. Which is the tumor suppressor gene here? APC. So both copies of APC should be lost. So first copy of APC is lost, then the second copy of APC is lost. Once the APC is lost, beta catenin gets activated. So this will lead to activation of beta catenin. So whenever we have APC mutation, then beta catenin should get activated. So that those options are correct now. So once you know this much, you know we are left with only two options here. That is APC and beta catenin. Now once we are clear with this, so both the options are correct only, looking like correct only one is missing in one. Yes, yes, one is missing. No, there is one difference, one basic difference. Now the second clue that you have to remember always, telomerase activation is always the last step. Okay, so telomerase activation is always the last step. So telomerase should always come in the last. So that's it. That's enough for me. The answer is A. So even if you don't know anything in between, you should be very clear. First two APCs are lost, beta catenin is activated, and after that last should be telomerase activation. So anything in between can occur. So let's see what occurs in between. So we know APC is lost, beta catenin is activated, and after that we can have various mutations. Now KRAS is again a proto-oncogene which is converted into oncogene. So KRAS is activated, P53 is deleted, SMAD is deleted, and the last is telomerase. So you should be very, very clear with the answers here. So in this kind of sequence question, always rule out first, exclude the wrong option. So go take a wider option, exclude and start excluding. Okay, so exclude out the wrong, then you are left with correct. Then think about one thing which you know about the correct one. Okay, like I remember telomerase is the last thing, so I choose this. So first two and the last was correct, so I knew I was in the correct answer. That's how you approach these kind of questions, and the answer is A. Right guys, now let's come to this another hemat question. Okay, so this patient has giant platelets, he also has thrombocytopenia, and he has cytoplasmic inclusion in the neutrophils. So what is this characteristic of? So guys, this is another repeat question in the exam. So this question has been asked in the exam approximately 2 to 3 years back. So you should always be remembering this. So patient presenting with giant cytoplasmic granules in the neutrophils along with giant platelets, and because these giant platelets are so big that they are of the size of RBC, your Coulter machine counts them into the RBC. So patient presents like, so it presents with thrombocytopenia. So these disorders are called as MYH9 gene disorders, and one of the characteristic gene here is MYH is May-Hagelin. Okay, so one of the characteristic disorder is May-Hagelin anomaly. So May-Hagelin anomaly is a characteristic MYH9 gene disorder which presents with giant platelets and with inclusions in the neutrophils. Okay. Pelgott-Houghton anomaly is binucleate neutrophils. Wiskott-Aldrich syndrome is small platelets. It's typically remembered as TI. It presents with three things: thrombocytopenia, immunodeficiency, and eczema. And the platelets are usually small here. Okay, so platelets are usually small here. Okay, so that is it. And the gene here is VASP gene, and it's an X-linked disorder. It's an X-linked disorder. Gray platelet syndrome is a disorder because of abnormality of alpha granules. Okay, so alpha granules of the platelets are not there. That is why it is called as gray platelet syndrome, and patients usually have bleeding symptoms. Okay, so let's look at this microscopy. If you look at this, look at the size of the platelet. Platelets should have granules in them. That's they are must to identify. Okay, very good, Aruneshwar. Okay, so these are platelets, and the platelets are equivalent to the size of RBC, so they're giant platelets. And look at these inclusions again in the cytoplasm of the neutrophil. So these are Dohle body like inclusions. Again, this image has been from ASH image bank, a very beautiful image to just show it to you. It's not for any publication purpose, right? So these are just giant platelets along with the inclusions present in the neutrophils. So these are nothing but, these are very, very characteristic of MYH9 gene disorders. Okay, May-Hagelin syndrome. Now, remember the other conditions also. So look at these platelets. So when they stop showing their granules and they appear a little pale, these are called gray platelet syndrome. They usually bleed. Okay, right? Okay, and also look at these are binucleate neutrophils, which is also called as Pelger-Hute neutrophils. Okay, Pravesh. So Coulter, when we talk about, no, Coulter is a machine which counts cells. It can count on the basis of two principles. One is impedance, the other is flow cytometry. So on the basis of impedance, it just takes the size of the cells and separate this. So it has the cutoffs for every size. So it has cutoff for the platelet, for the RBC and the WBC. So on the basis of the cutoff, it separates them. Okay. So suppose the cutoff starts merging, like platelets become so large as RBC. So what will Coulter do? He doesn't have eyes. No. So what will he do? He'll start counting all the platelets as RBCs, and patients, Coulter will give you as thrombocytopenia. There might not be true thrombocytopenia, but Coulter will report thrombocytopenia. That is why it is very important to see the smears in cases of thrombocytopenia, so that you don't miss this kind of lesions. Okay, and then we also have flow cytometry, which is present in the Coulters, which is used for a lot of purposes. Now, if you look at the 5-part Coulter, so it can separate the neutrophils, eosinophils, basophils on the basis of the fluorescence. Even the reticulocytes are also picked up on the retic channel. So that is the principle of the Coulter. Okay, guys. Right. Apart from that, I've just shown you a gray platelet syndrome and a Pelger-Hute neutrophil. Pelger-Hute neutrophils are usually inherited, and they can also be seen as acquired when they are called as pseudo-Pelger-Hute anomaly, which can be seen in myelodysplastic syndromes and very rapidly proliferating marrows like CMLs. Okay, right. Now, once you are clear with this, now quickly let's see what are the other MYH9 gene disorders. So remember, we have May-Hagelin anomaly, Fechner's anomaly, Sebastian syndrome and Epstein syndrome. So these are 4 MYH9 gene disorders, and this gene is present on 22q, and this gene is present in kidney, leukocytes, cochlea, platelets, and that is why these patients usually present with, kidney dysfunction, deafness. Okay, that is why you should be knowing it. So these 4 disorders, if you make a chart, okay, so May-Hagelin we have just now talked about. Okay, so what is unique is Fechner syndrome. Fechner syndrome has nephritis, deafness and cataract all together, whereas Epstein syndrome, whenever I'm talking about, they have nephritis and deafness and there is no cataract. So these are all the giant platelet disorders. Okay, usually they'll not be asked into your exams. I'm just giving you a clue to just remember that these are actually your MYH9 gene disorders. So just to give you an overview of it, that's it. Okay, right. Coming to the next question number 13, fixations. Okay, very important topic for your exam point. So you should know what are the fixations. So what is a fixator of pap smear? That's a googly question. Everybody should know this. What is the answer to this? Fixation of pap smear is usually done by 95% ethanol. That's the fixator of pap smear, which everybody knows. Okay, so that is one fixation. So usually, whenever we have a cellular fixator, okay, cells we have to fix, we usually fix it in alcohol. Okay, alcohol is a good fixator for cells. Whereas if somebody asks you what is the best fixator for biopsy, okay, for biopsy the best fixative that we use is 10% buffered neutral formalin. Okay, that's a fixative for biopsy. Now let's come to some tricky questions. So if you have attempted the ELITE quiz, so then you will be knowing these questions already. Okay, so question number 16, I am merging 13th with 16th. Okay, so let's look at the question number 16th. Okay, so if you look at the question number 16, what do you see here? So you see they have asked you fixative of choice for this technique. So what is this technique here? This technique is karyotyping, and fixator of choice for karyotyping is always Carnoy's fixative. So Carnoy's fixative is a fixative for karyotyping. So again, in options they have given Sacco-Mano fixatives. What is Sacco-Mano fixative? So if you look at and compare these two fixative here which we have talked, see Carnoy's fixative is one of the best fixative for karyotyping. So it contains ethyl alcohol 60%. Along with that, it contains chloroform and glacial acetic acid. So that's a fixative for your karyotyping. So it contains glacial acetic acid. If you talk about Sacco-Mano's fixative, it has 50% ethyl alcohol and it contains 2% carbovax, and it is a very good fixative for sputum. Okay, so it is sputum and fluid. Okay, like pleural fluid if you have to fix. Okay, so in cytology if you have to fix pleural fluid, pericardial fluid, or sputums, that is done in Saccomanno-fixatives, whereas in Carnoy's fixative is a fixative for karyotyping. Michel's media is actually a media for immunofluorescence, okay, and Carne is nothing, it's Carne's triads and syndromes which is there, okay, right. So these are the fixative, common fixative that you should remember. Formalin for histopathology. When we talk about cellular fixative, 95% ethanol is best for pap smear. Decrease the concentration to 60%, add glacial acetic acid, it becomes Carnoy's fixative for karyotyping. Decrease the concentration of alcohol further to 50%, add 2% carbovax, it becomes Saccomanno fixative, which is a very good fixative for sputums and pleural fluids. That's about fixatives, which everybody should be very, very, very clear, right? Now, coming to the easy question, okay, and one of your favorite question. I know all of you, this is your favorite question. So look at this. This is your orphan ani nucleus, which you're seeing, and the nucleus are all clear here, and they've asked you which is the most common mutation in this tumor. So orphan ani nucleus is a fixation artifact. That's why I purposely gave this question. It's a fixation artifact. Remember that always. That is, this is one change in papillary carcinoma of thyroid which will be seen only on biopsy, and it will not be seen on FNACs, okay. That's one point you should remember. If somebody asks you what is the mutation you see here, remember the most common mutation that you see in papillary carcinomas of thyroid are BRAF mutations. So they are very commonly associated with BRAF mutations. This is the most common mutation of papillary carcinomas of thyroid, you have to remember, okay. So RAS mutations are very common in follicular carcinomas of thyroid, okay. RET mutations are very common in medullary carcinomas of thyroid. So if you make a chart, BRAF mutations are very common in papillary thyroid carcinoma, RAS and follicular, RET and medullary. That's the gist about thyroid cancers, which all of you should remember, okay guys, right. Okay, so very good. So this is answered correctly by Arvind and Satish. Perfect. Okay, so and Sanyatan also. So all of you answered it correctly. Perfect. Okay. Let's go to the next question. So again, a very important repeat question, okay, previous year question. Which of the following represents a marked area in the histology of the lymph node, guys? So this central part of the lymph node is always, all of you know, this is the germinal center. So this is the germinal center which you should remember here, okay. And of course, you remember this dark blue color cell here is your mantle zone, okay, and marginal is outside, paracortical is outside, okay. So this was very important question, okay, which was asked to you. So this is germinal center. I hope all of you remember which all tumors arise from germinal center. Remember follicular lymphoma, Burkitt lymphoma, Hodgkin lymphomas, okay, and DLBCLs. So these are tumors which can arise from the germinal center of the lymph node. Mantle lymphoma, mantle cell lymphoma arise from the mantle zone, okay. Paracortex is the T-rich area. Marginal zone usually give rise to maltomas, okay. So maltomas usually arise from the marginal zone area, right? Okay guys, very good. So who all answered correctly? Let me see. Yes. So Priyanka Mehta and Sanyatan answered this question correctly. Full points guys, right. So who's going to tell me this? Which marker is closed down in germinal center, normal germinal center? So whenever it is a normal germinal center, remember one point, they do not have BCL2, okay. So BCL2 is not present in normal germinal center. Remember that point always, right? Okay, right. So quickly revision, somebody is asking what is the marker for mantle cell lymphoma. Quickly tell me. Mantle cell lymphoma, you all of you know this is translocation 11-14, and they usually express, remember the most commonly used marker is SOX11 and cyclin D1. So they are the markers for mantle cell lymphoma. Okay, so I'll write it here. So if you want to quickly make a recap. So here is a quick recap, okay. So mantle cell lymphoma, quickly tell me the markers. They are positive for cyclin D1 and SOX11, and if somebody asks you mutation, it is translocation 11-14. Perfect. Coming to the germinal center, we have Burkitt's lymphoma. Burkitt lymphoma is positive for c-Myc and their Ki67 is 100%, okay. Okay, Harsh, no problem. Okay, and what is the translocation? Everything according to the 8, 8, 14, 2, 8, 8, 22, everything on 8 is Burkitt's. It's c-Myc positive, okay. Coming to the follicular lymphomas. Follicular lymphomas are the tumors which are BCL2 positive. Normally germinal centers do not contain BCL2, but these are something which are BCL2 positive. Okay, so and apart from that, they are also positive for CD10. Okay, CD10 is positive, BCL6 is positive. Okay, and whenever we talk about follicular lymphoma, the translocation typically is 1418. That's the translocation of follicular lymphoma. Coming to the Hodgkin's lymphoma, you know the gene which is involved here is REL gene. The marker, if it is a classical Hodgkin's, is CD15, CD30. Whereas if it is not classical, nodal lymphocytic predominant Hodgkin's, they are positive for CD20. Okay, right, and they will be positive for CD45. Right, now coming to this next, the last one is DLBCL. Okay, so DLBCL can be arising either from marginal zone or from the germinal centers. Okay, and they usually have BCL6 mutations, and they are usually positive for CD20. Okay, CD20. Right. So that's the gist of lymphomas that all of you should be remembering. Right. Thank you, Krishna. By the way, what did you like? Which explanation did you like? I will be so happy to know that. Okay, right. So that's the gist of all the lymphomas which you should remember. Right, super easy. Okay guys, now once we are clear with this, now let's come to question number 17 again about lymphoma. So we have talked about B cell lymphoma. T cells feel neglected. They say, come on, take me in. So this T cell lymphomas are anaplastic large cell lymphomas. Let's take them in. So T cell lymphomas, okay. Not true about anaplastic large cell lymphoma is what is not true about ALCL. So whenever we are talking about ALCLs, guys, these are T cell lymphomas and they contain very special cells. Okay, these cells are called as hallmark cells, and hallmark cells, if you remember, so they usually have either a horseshoe shaped nucleus or sometimes they will become perfectly rounded like this, and this is called as donut shaped nucleus. So these are hallmark cells which you should remember, which are very characteristic of ALCL. So they have donut shaped nucleus or a nucleus with horseshoe shape, and they typical. So they asked you what is not true about ALCL. See, whenever the ALCLs are positive for ALK, okay, so the translocation is always 2-5, and if they are ALK positive, this gives them a good prognosis because you can give targeted therapy against ALK and you can treat these patients. Okay, so that is why it's becoming super important to diagnose if they are ALK positive or not. Okay, so all ALK positive tumors always have a good prognosis. Rest everything is correct. Remember, apart from Hodgkin lymphoma, classical Hodgkin lymphoma, which is CD30, ALCLs are also CD30 positive. Okay, so ALCLs are also CD30 positive tumors. Remember that point always. Okay, super important. Okay, and there was an entity which came recently, and WHO has also added it in the main classification, which became very popular, called as BIA. Who is going to tell me what is BIA? Breast implant associated ALCLs. Okay, so breast implant associated ALCLs, you know, approximately 8 to 10 years back, usually the breast implants became common, and then the females who had put breast implants then started getting some effusion around the breast implants. So the latent period was very long, approximately 8 to 10 years, and after 8 to 10 years they started developing this effusion around the breast implants. Then when they studied them, they found that it was actually ALCL which was occurring around the breast implants. So this is called, this tumor is called as BIA. This tumor is called breast implant associated ALCLs, and they usually have a poor prognosis and they have ALCLs around them, right? So this is, somebody can ask you, okay, so somebody can ask you that what is BIA? BIA is basically breast implant associated ALCLs. Thank you, Gaurav Jha. Thank you so much. But which explanation did you like? You have to tell me that. Okay, right. Now coming to the question number 18. So when we talk about question number 18, so which instrument is shown below? So this instrument is shown below and it is used for what? So remember, the instrument that is shown here is very typically, you all know what is this. This is actually a holder and there's a needle and there are slides. There are nothing. This is for FNAC. So this technique is basically an FNAC, fine needle aspiration cytology, which you do, and usually the gauze size of the needle that you use is approximately 22 to 25 gauze needle. Okay, that's a special gauze needle that you use for FNACs, and it is very important to you for you to know. Remember, what is the difference between the gauze size of biopsies and FNACs? Yes, it is 14 to 18 gauze in cases of biopsies usually, and FNACs are usually 22 to 25 gauze. They are very thin needle. Why do you use so thin needles? Because you don't want blood to come, because if blood is coming, it will obscure all the cells. FNAC is basically for aspirating cells. You don't want any blood, so it has to be done with very thin needle. Okay guys, right? Okay. Okay, so now let's come to the question. Okay, Harsh and Kadambati. Okay, so this might be because of your internet, or do you think it is an fault from my end? Okay, let's come to the next question. Okay, so disorders associated. Satish. So okay, shall I wait, or is it because of net issue? Why is Rajeshri? Why is the screen hanging? What can be the cause for this? Okay, thank you, Gaurav Jha, for your germinal center and mantle zone. Thank you, super. Right. Now let's come to the disorders associated with defective apoptosis. Okay. Okay, Harsh, I'll try my best. Maybe my net is slow. That can also be an issue, isn't it? So, guys, do let me know if you like this question, quick rapid fire question type sessions, so that we can have them more often. Okay, that's very, very important for your feedbacks are most important. Okay. Thank you, Faisal. Let's go to the next question here. Disorders associated with defective apoptosis and increased red cell survival. So, guys, whenever we have defective apoptosis, all the self-reactive T cells will not be killed and they will start attacking our own body cells. So, autoimmune disorders usually occur because of defective apoptosis. All the other disorders like neurodegenerative diseases like Alzheimer's, where the cells start killing themselves. So, there is a lot of apoptosis, or viral infected cells which will kill themselves. So, all they are because of increased apoptosis. Whereas disorders of defective apoptosis are very typically autoimmune disorders. Right. Let's go to the next question. Okay. Okay. Okay, guys. Thank you. Thank you, Vishnu Priya. Yes, thank you for telling me all that. Thank you, Vishnu Priya, Satish, Kadamti. Yes, thank you so much. Yes. Thank you, Vignesh. Yes, definitely. I am thankful to you for saying that you're loving the session, and definitely we'll try to have more of such sessions. Definitely, definitely, definitely. But let's finish this first round of questions, and then we will chat. Okay, then we will chat with each other. Okay, let's go to the question number 20 here. Okay, so in a patient with non-mismatched blood transfusion reaction, what should be done first? So if suppose you have given if you have given a mismatched blood, okay, to somebody, what should you do? Okay, so what should you do if there is a mismatched blood transfusion? What should be the first strategy that you should do? See guys, whenever you have this, first strategy should always be stop the transfusion. Remember, that's the strategy which we follow whenever we give you mismatched blood. That's the rule. First thing that you should do is stop the transfusion. After you've stopped the transfusion, perform quickly the clerical checks. Okay, do the clerical checks to see if there was some error. Okay, and then after that, what you do is you do that. The next thing that you always do is direct Coombs test. That's the order we do. Okay, stop the transfusion, check all the clerical checks, and we do direct Coombs test. So to see if any red cells are coated by some antibodies. Okay, so you pick that up. After that, you take if there is any hemoglobinemia and hemoglobinuria which is occurring, and then do check again the ABO and RH grouping, and then you do indirect Coombs test also. So that's the approach that we do whenever we give a mismatched blood. Stop the transfusion, do the clerical checks, do the direct Coombs test, because there was once a question which was asked in which stop the transfusion was not the option, and the question was the same, and they asked you what will you do first, and this was not in the option. Suppose this is not in the option, what should be done now? First, direct Coombs test. You understand? So it's a sequential option. Okay, so first you stop the transfusion, then you do the clerical checks, then you do the direct Coombs test. Like that, you have to go in a stepwise manner. Yes, very, very, very good. Thank you guys. Perfect. Now let's come to the question number 21. So question number 21 is a bladder question. Okay, so bladder is one again very important topic that can be asked in your NEET PG and INI-CET questions. Okay, so very important topic. So let's look at this lesion. Okay, so this person has a soft yellow raised mucosal plaques approximately 3 to 4 centimeter in diameter in the urinary bladder. So look at these and they ask you what can this be diagnosed, what can be the diagnosis of this condition. So whenever you see these kind of mucosal plaques, guys, you should be very clear that these kind of mucosal plaques are very characteristic of malacoplakia. So malacoplakia is an entity which occurs in the urinary bladder, and I hope all of you would have heard my story of this. You know, there was a saint who used to convert the person into stone. वो कहते हैं ना पत्थर में तुम पत्थर बन जाओगे उस type का. So urinary bladder has lot of problem that they have lot of E. coli infection. So what happens in people with malacoplakia is their macrophages cannot kill this E. coli. So macrophages cannot kill this E. coli. So what do is they can't kill it, so they calcify it. So these E. coli gets calcified. So it turns into calcified bodies, and calcium is usually a bluish color material which can be seen, right? So these bodies are called as Michaelis-Guttman bodies. These bodies are called as Michaelis-Guttman bodies. Okay, very good. And this superman macrophage which converts, okay, E. coli into bacteria, they are called as von Heinzmann macrophages. Okay, so they are called as von Heinzmann macrophages because they convert that E. coli into stone. Okay, so this entity is called as malacoplakia, guys, and you remember that because the calcium is so small, it has to be stained with a special stain, and the special stain that we use here is called as alizarin red. That's the stain which we use here. So alizarin red is the stain for calcium which is used whenever the calcium content is very less. Okay, so alizarin red is the stain which we use here. So this is all about malacoplakia. So once you're clear with this, let's look at the microscopy of malacoplakia. So microscopy of malacoplakia is going to show you these small, very small calcified deposits, and they are called as Michaelis-Guttman bodies, which all of you should remember. But there was another option here which was very important, xanthogranulomatous pyelonephritis. So this, guys, is again a very important image based question that can be given to you. So what happens in xanthogranulomatous pyelonephritis is you see dilated calyces like this. There's dilated calyces. Sometimes even pus can be filled inside the calyces, and you can see this yellowish color material deposited here. So whenever this yellowish material is deposited here, this actually gives a clue to xanthogranulomatous cholecystitis, guys. And if you look on the microscopy, there will be these all foamy macrophages will be infiltrating into the stroma. So there will be a lot of foamy cells here. So whenever you look at this image, dilated calyces with the yellow color material with presence of lots and lots of foam cells, it's very typical of xanthogranulomatous cystitis, which you should remember, or pyelonephritis. It can be given to you anywhere. So whenever I'm talking about kidney, it's called pyelonephritis because I'm showing you dilated calyces. So dilated calyces, yellow color material, foam cells, it's xanthogranulomatous pyelonephritis. Very good, everybody. You all have answered correctly. I'm so proud of you all, guys. Okay, let's go to the next question. Okay. So this is a 45-year-old male because he is presenting with the diagnosis of hereditary hemochromatosis. So which is not the correct statement here. Let's see how many of you can answer this. Which is not the correct statement here. So let's go to the correct statement first. Okay. Okay. So let's go to the correct statement. Damage to the organ results from abnormal deposition of hemosiderin. Yes, that's perfect, clear. So it is due to deposition of hemosiderin. It can progress to CID. Remember the code: cirrhosis, infertility, and diabetes. Whenever occurs in a person, you should always think of hemosiderosis. So cirrhosis, infertility, and diabetes. But they have given here cirrhosis, pigmentation, and diabetes. So it's okay. Pigmentation occurs because of hemochromatosis. Apart from that, most cases are due to H3D mutation. Absolutely wrong. This mutation is not seen in hemosiderosis. That's wrong. wrong. It is seen, but it is not very common, okay. So it's a second common mutation. The most common mutation I'll just show you now after this. And skin hyperpigmentation is due to melanin. Yes, so skin hyperpigmentation which occurs in hemosiderin is very characteristic because it occurs due to combination of hemosiderin and melanin, and that is why the pigmentation is very characteristic. It is due to melanin, yes, mostly, but hemosiderin, small amount of hemosiderin is also there, and TIBC is decreased. You know, always iron is inversely proportional to TIBC. So if your iron content is high, your iron binding capacity will be low, right? So that's also correct. So the answer is C. Remember, HFE gene mutations are most common, and the change here that is most common is C282Y. That's the most common mutation which occurs in this patient. So this is C282Y mutation, which is the most common mutation of hemosiderosis, and you should remember it's a very important point that can be asked you in exams, right guys? Everybody of you answer correctly. My god, super intelligent students, right? So now again this is a repeat question which was asked. Identify the correct sequence of events in acute inflammation. I hope everybody knows that first there is a transient vasoconstriction. This is followed by vasodilatation. Vasodilatation occurs in arterioles predominantly, so more blood is going to the tissue. After that, this is followed by increased vascular permeability, which occurs in the venules. So because the fluid now goes out, so now only cells are left, so this causes stasis. So remember, there is always transient vasoconstriction followed by vasodilatation, followed by increased permeability and stasis. That's the correct options. Very good, Sanyatan, you answered it perfectly first. So you get a chocolate, right? So that is your the correct acute inflammation order, which all of you should be knowing. So remember, it is always vasodilatation. Vasodilatation occurs in arterioles, so blood goes very fast. It never causes stasis. Remember that point always, okay? So vasodilatation always occurs in arterioles, so blood will become faster, not slower. Only after increased permeability, when the fluid goes out, the blood becomes slower. Remember that always in your brain, okay guys, right? Now let's come to the question number 24, again about cells which we read less often, so I just gave you this question. So this is a 70-year-old male. He presents with the left-sided paraplegia, left-sided hemiplegia, and this is because of damage of which type of cells? So basically I wanted you to know labile cells, permanent cells and stable cells. So just to tell you the update, so everybody knows what are labile cells. Labile cells are continuously dividing cells like skin cells. What are stable cells or quiescent cells? See, when normally they have low level of replication, but you can push them to divide whenever your need arises, like kidney cells, okay? So regeneration always occurs in labile cells and stable cells. Now there are permanent cells which are not able to divide, they have left the cell cycle, and whenever healing will occur in these cells, it will always occur by repair. That is, extracellular matrix will be formed and a scar will be seen, okay? So now the question was that this is a patient who has got hemiplegia. Which cells are damaged? See, hemiplegia basically damaged neurons, which are permanent cells. So it is basically damage to permanent cells, and they will heal only by scarring. Very good, Satish, you answered it perfectly, and Vishnu Priya also, you answered it perfectly. Full marks, right? Okay guys, let's go to the next question. So this is about electron microscopy. This is an electron microscopy that is given, and they asked you what is this electron microscopy suggestive of. So they showed you some fibrils which were non-branching, infinitely long, but the diameter was fixed, 7.5 to 10 nanometer. So this has, so guys, when this has to be amyloid, okay? So whenever I'm giving a fixed diameter, remember the diameter is fixed, always remember that. Infinitely long fibers with the fixed diameter, it has to be amyloid, okay guys? This is always an electron microscopy of amyloid. Whereas, look at this, now when they give you negatively needle-shaped crystals, okay? Needle-shaped crystals, negative birefringence and needle-shaped crystals. Remember the code GUN, okay? So gout, if I'm ever talking about gout, it has monosodium urate crystals, and they are always needle shaped and they have negative birefringence. So gout is always GUN, okay? GUN is gout, always needle shaped crystals, negative birefringence, and they always needle shaped, okay? Whereas when I talk about pseudo gout, remember the code PCR, okay? So they are always, so whenever I'm talking about PCR, pseudo gout has calcium pyrophosphate crystals. Okay, so they are always calcium pyrophosphate crystals, and they're rhomboid shaped. Okay, so they're like this, they're rhomboid shaped crystals. Okay, so always remember that, guys. So they're rhomboid shaped crystals and have positive birefringence, and if you stain them, they'll appear like these. Okay, so they are pseudo gout crystals which can be seen. So crystals, whenever they're giving you, you have to remember gout and pseudo gout, and on electron microscopy you have to remember infinitely long fibers with a fixed diameter of 7.5 to 10 nanometer is always a myeloid. You should never ever forget it, right? Now let's come to the next question. So this is not true about polyglutamine diseases. So remember, guys, whenever I'm talking about polyglutamine diseases, polyglutamine means CAG, CAG, CAG. What is this? Trinucleotide repeat diseases, okay, which occurs in the coding sequence. So whenever the trinucleotide diseases occur in the coding sequence, CAG, 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 these are called as polyglutamine diseases, and they will typically cause intranuclear inclusions. They will typically show you these intranuclear inclusions, and the characteristic prototype of, who can tell me the trinucleotide mutation which occurs in the coding region, is Huntington's disease. So Huntington disease is a very, very characteristic polyglutamine disease. Okay, apart from that, spinocerebellar ataxia. So remember this revision: trinucleotide repeat diseases can occur in the coding part of the DNA, or they can occur in the non-coding part of the DNA. Okay, if they occur in the coding part, this is Huntington's disease and spinocerebellar ataxia. And in all of these, the sequence is always CAG. Whereas in non-coding, when I'm talking about, this is fragile muscle. Okay, muscle is myotonic dystrophy. Fried is Friedreich ataxia, and fragile is Fragile X. Everybody knows Friedreich is fried foods you don't eat nowadays, GA. Fragile X is mentally retarded, so CGG. Okay, and myotonic dystrophy, the repeat is CTG, right? So these are trinucleotide repeat diseases which are, okay, which you should know. Whenever excess CAG is formed because they occur in the coding part, these are also called as polyglutamine diseases, and that was the question which was asked, which is not true about polyglutamine diseases. They typically show you intranuclear inclusion, they show you neurodegeneration. Huntington disease is a prototype. Parkinson is not a prototype of your trinucleotide disease. Okay, in Parkinson's, the typical thing that you see is cytoplasmic inclusion, which are called as Levy body. Okay, Levy body, okay, which are made up of alpha-synuclein. Okay, so they are not polyglutamine diseases, right, guys? Okay, let's go to the next question. Quick. Identify the pedigree in this case. So it's super easy, isn't it? When father is affected, nobody is affected. When mother is affected, all the children are affected. When father again is affected, nobody is affected. When mother is affected, everybody is affected. Mother is affected, everybody is affected. Very characteristic mitochondrial inheritance. So that is your mitochondrial inheritance pedigree. Pedigree is a very important question, guys. So you should know how to identify the pedigree, right? Now let's go to the next question. True about this technique. What is this? This technique is called as array CGH. Okay, so all of you who have heard me ever before will know the story behind it, which I'm not going to tell openly on YouTube. It's a secret story. Okay, so that's an array CGH, and whenever I'm talking about array CGH, basically remember it gives you only two color options. It gives you green and red options, and when red and green comes together, it gives you yellow. Okay, so basically it can allow you to visualize 100 of genes together. That's the purpose of array. Yes, and it is called as gene microarray, and CGH can be done on it. Obviously, this is just array CGH only. This is called tissue microarray. Is absolutely wrong. Tissue microarray is when you put the same thing on when you put tissues in an array. Okay, so you make a chip and in that you start putting tissues. That is what is called as a tissue microarray. So tissue microarray is different from this. This is gene microarray and you do a CGH on it, and that's the technique, right? Okay, guys, let's come to question number 29. Something about, again, joints is another very important topic which we don't study, but they're asked very frequently in exam. So this is again a joint question. So this is a 47-year-old woman who has increasing pain and deformities of her hand and feet for the past 10 years, and she has a joint swelling, erythema and tenderness. Synovium biopsy was done for the diagnosis. Microscopic examination, all of you can see this. This is nothing but a lymphoid follicle is seen. What is your probable diagnosis? So everybody should remember lymphoid follicles in the joint whenever you are seeing, okay, along with the classical history of joint deformities and long standing disease, this is very typical for rheumatoid arthritis. Okay, this is very typical for rheumatoid arthritis. Remember, the main culprit in rheumatoid arthritis is CD4 cells. Okay, so basically what happens is the antigen presenting cells present the antigen to CD4, and what will happen is, let's see here. So antigen presenting cells present antigen to CD4 cells, and these CD4 cells will either change into Th1 or they will change into Th17. Okay, so Th1 means they will release interferon gamma and activate the macrophages. They will activate the macrophages. Also, they will activate Th17 to activate the neutrophils, okay, to activate the neutrophils. So they'll activate the neutrophils. So these macrophages and monocytes will be activated. Apart from that, so what will happen? They are again antigen presenting cells. So what will happen is they will start recognizing some antigen also. So they found that there are certain antigens which are very prudent to cause this disease. So what is the typical antigen? So here the antigens are citrullated peptides. So your body starts making anti-citrullated peptide antibodies, which are very characteristic of rheumatoid arthritis. And also rheumatoid factor is seen. What is rheumatoid factor is another question that they can ask you. This is nothing but IgM and IgA antibody against FcIg regions. Okay, so against IgG. Okay, so this is IgM and IgA autoantibody against IgG is called rheumatoid factor. So this is present in the blood, and if you look at this, what is happening is, if you look at this, so they are, these CD4 cells and these B lymphocytes and the macrophages are continuously damaging the synovium. So what will happen after a point of time? Repeated injury cycles will occur and synovium will start proliferating, and you will start seeing something like this. The synovium has started proliferating, and there are a lot of inflammatory cells in this, lot of lymphoid cells, plasma cells, everything is there. So synovium is proliferating here. Synovium is proliferating and it will form papillae also. It will start protruding, form papillae, and below that papillae there will be lymphoid follicles. Okay, so there will be lymphoid follicles which you can see. So there will be lymphoid follicles, there will be plasma cells, macrophages, all will be there. Apart from that, you should also remember that after a point of time, what is going to happen is osteoclasts are going to get activated and they will start eating the joints. They'll start eating the bone. They'll start resorbing the bone. So whatever we have started here, so can we relate to these four findings simply? So there is synovium hyperplasia and proliferation because of repeated injury, and a lot of TNF, interleukin 1 is excessively released there. So these are major culprits. So TNF, interleukin 1, CD4, plasma cells, B cells, everything is there. They cause repeated injury to the synovium, which starts causing hyperplasia. So this hyperplasia of the synovium with lot of blood vessels in it, this is called pannus. Okay, below this you see a lot of lymphoid follicles. There is also fibrinopurulent exudate on the synovium because neutrophils were also activated. So this is over the pannus. So pannus is just not synovium, it is also the exudate which is present along with that. And after a point of time, osteoclasts will get activated, which will start causing, they will start eating the bone. So it will cause periarticular erosions and subchondral cysts. So if you look at if you look at this, it is very classically explained by this. So this joint has a lot of growth of the synovium and inflammatory cell. This is what is called as pannus. And after a point of time, the bones will also be eaten off. That is your rheumatoid arthritis, which you all have to remember. So this was whenever you see a lot of lymphoid follicles, okay, below the epithelium, rheumatoid arthritis is a very strong option, and you have to remember that, right? Okay, and CD4 cells are the major culprit, remember guys, okay? Now the last question of the day, question number 30. Enough questions, we have discussed lots and lots of questions. It's going to be 9, will not go beyond it, right? Full house effect is seen in which condition? All of you know full house effect means presence of IgG, IgA, IgM and the complement proteins together with fibrinogen is called full house effect, which is typically seen in SLE. So full house effect is a very classical thing which is seen in SLE. So guys, keep reading and keep practicing. You are definitely going to win, because this is the crucial time now. There are very few days left for your INI-CET exam. NEET PG exam is also coming soon, running to you. Okay, FMG is also coming. So everybody, so there are a lot of exams which are updated, going to come now, especially INI-CET is just near the door. So all of you should be practicing and reading well. Guys, you can follow me on my Facebook group, Dr. Vandana Pathology is the Instagram handle which I have. Okay, so Dr. Vandana Pathology, you can follow me on my Instagram. Okay, and my video lectures are present on Doc Tutorials. Okay, and my Facebook channel is Dr. Vandana Pathology Study Circle, which you can follow me, and this is the YouTube channel which you are seeing here, and that's Dr. Vandana Puri. You can follow me. So there are lots and lots of social media handles which I have. Okay, so you can follow me wherever you wish to. For any doubts, feel free to message me. I reply super fast on Instagrams. I have a Telegram channel, but I'm very slow on it. So pardon me for that, but I'm super fast on Insta. You can message me anytime. You can message me on Facebook also. I can answer that also. And yes, YouTube is always an option. Do keep following me, and if you have any queries, feel free to ask me anytime. And do let me know if you like the test and discussion videos. Do like and subscribe, and definitely I will be posting more videos if you like them, right? Let me know. Yes, your feedbacks. Bye guys, good night, have a good sound sleep, eat well and read well. Bye bye.